have to calibrate it with your finger stick. And most the devices need calibration twice daily, so it doesn't replace the finger stick checks. Again, FDA has told us that you have to confirm the reading that the sensor gives you with a finger stick before you make a decision. And for the same reasons that you mentioned, if a patient kind of sticks to the sensor and wears it like 24/7, that's when they see benefit. If you think that it's not great, it may not really benefit you that much. And the Medtronic sensor has been approved for children age 7 to 17 and adults. And the other one, the Dexcom, is only approved for use in adults. Now, how could the system improve, right? So that's so now we are on the sensor issue. Let's talk about the Enlight. So this is what has been indicated, used in Europe for adults and children. In US, we don't have it yet, but this is a newer generation of the sensor. They claim that the accuracy in the hypo range, it has improved by 26%, and it catches up to 98% of all the events. So we have to see the data, but it's very promising. They have about 70% reduction in size, and you can use it up to 6 days. The one that we have here, you are recommended to change it every 3 days. So they are working on it. More interestingly, they have a pump also that, again, unfortunately we don't have it here, but in UK it's been approved and is being used. It's called Paradigm Veo. So it has low glucose suspend, which is a great feature. It all makes sense. When the patient wears it with the CGM, if the blood sugar is going low, and these sensors, these devices have the algorithms that they can kind of predict if your blood sugar is changing too fast, like in 20 minutes, you might be good now, but in 20 minutes you're going to be in hypo range. So then the alert goes off, and it goes off twice to kind of wakes the patient up, or alerts them to suspend the pump. But if that doesn't happen, the Veo system suspends the insulin for 2 hours. So main goal here is to avoid hypoglycemia, especially nocturnal hypoglycemia, especially in our young patients that we don't want them go low overnight. So for me, this is a very good feature, makes all the sense. So hopefully we will have trials done in the US, and we will have it in the market very soon. But again, these are all little steps towards that artificial pancreas, which would be the goal, the target. So that one was the Minimed. This is the Navigator, which is not in the market anymore. And we have Dexcom, which is which one of the sensors were you wearing, sir, if you don't mind me asking? Dexcom or the other one? GlucoWatch? One of the with Novolog. Okay. The Paradigm? Okay. Anyway, the one that talks to the pump, right? With the pump? Okay. Yeah. There's only one that actually is integrated inside the pump, and that's the Medtronic. Oh, was separate? So you couldn't see the number on the pump, right? Or you could? On the monitor. So it was either the Navigator or Dexcom. Okay. So this is, again, this one is separate from the pump. So patient wears that sensor and transmitter, and that's the receiver that shows the blood sugar. Actually, I have some patients that kid wears this kind of sensor and is in the soccer field, and mom has the screen outside the field and can see there. So it's actually quite helpful. This one needs to be changed every 7 days, and but again needs calibration every 12 hours. And although it is approved for adults, but we sometimes use it off-label for pediatrics use. So we have had this clinical guidelines since 2007 for the use of sensors in patients that they have unstable glucose control, or they haven't been able to achieve their target, and can be valuable in nocturnal hypoglycemia and postprandial hyperglycemia, which is basically the story of our lives, right? We know that this is what diabetes is about. So let's look at the data. Let's look at some of the trials that shows how helpful, how useful these devices are. So this is a study from 2009, and showed that adults who used the CGM systems, they made these adjustments in their diabetes management, and 90% of them actually were happy. They wanted to repeat the CGM. This is one of the very first studies. This one, it was a retrospective chart review in a university-based clinical practice similar to here from 2006 to 2008. They had 118 patients. Most of them actually were adult, 14 to 70 was the age range. They had some patients with type 2 as well, and at least they were wearing the CGM for 3 months. Severe hypoglycemic events before or during CGM, the total was 43, but only 17 happened with CGM. Actually, this is one of there aren't many studies like this that shows that the severe hypoglycemic events drop with the use of CGM. Most of the studies show that the amount of time that the patient spends in hypoglycemia goes down, but this is a good one that actually seems that they had a lot less events like seizures, coma, unresponsiveness with the CGM, and so from 50 dropped to 17. That's really good. Their average hemoglobin A1C also dropped. Although these are the patients that had good control, their A1C was 7.5. It dropped with the CGM to 7.26. And the ones that used the CGM more often had more dropped. But again, this is you can look at it this way, that this is a population of patients that have good control. So they probably did everything by the book, really. So again, this is the JDRF study group reports that basically the Juvenile Diabetes Research Foundation since 2009, they have been run, since actually 2007, they have started this initiative towards artificial pancreas. They have this artificial pancreas project, and there are several, we are going to refer to a lot of their publications from now on. But this is one of their very first papers that 232 participants with they were all type 1 diabetics for more than 1 year, and they included both adults and children. It was a multi-center trial for in 10 centers. This was done, and they were either on insulin pump or MDI, multiple daily injections. And the ones that used used the CGM more than 6 times a week, they were like half of the patients, basically. Factors that affected more use of the CGM one was the age. So they kind of looked at their patients in 3 different age groups: younger than 14, 14 to 25, and older than 25. And actually, adults were the best users, and they also checked their blood sugar more frequently. They had the highest percentage of time spent with normal target glucose between 70 and 180, and they had the lowest amount of hypoglycemia or hyperglycemia. So basically confirms the same things that we just talked about. Like the more that you use the CGM and the more frequently that you check your finger stick, that they had better control. The group that had the least amount of adherence, and definitely typically had the least benefit were unfortunately the adolescents. And they also looked at their data, like depending on if the patient going into trial had good control or bad, or their A1C was higher, and both had actually the same results. So one of the so what improved basically with CGM was one was the number of hypoglycemic episodes, glucose less than 70, number of and the amount of time that they were outside the target, and also there was improvement in their A1C. But they showed that in their study, the amount of severe hypoglycemic events did not really change with the use of CGM, which is quite discouraging, was quite discouraging. And again, the same thing. And also the psychosocial factors associated with diabetes, like fear of hypoglycemia or the quality of life, that was also not reported as improved as we hear from a lot of our patients. So this first trial was not very was not the results that everybody basically was hoping for. Then what they did was the same JDRF study group. They extended their after 6 months of clinical trial with the study arm and the control arm. They extended the study on the control arm, and they gave them like a clinical setting. They gave them the CGM and one kind of training session and 4 clinic visits. So it was just more kind of more like what we do with our patients in our clinics. Wasn't as part of this study. These were like 214 patients, age 8 to 24, and again, they confirmed that children and adolescents didn't like it, didn't use it that often, but the ones that use it more often had better control. So kind of confirmed the same results. This one is actually the one that was published last year, and it actually has the best results, the STAR3 study group. So again, both adults and children with 329 adults, 156 children, age 7 to 70, multi-centered trial. The range of A1C was a little higher, 7 to 9.5, and they were either randomized to two arms, either sensor augmented CGM and pump therapy, or just the multiple daily injections. And the A1C before going to the trial in both groups, both arms, was like 8.3, dropped to only 8.1 in basal bolus, but with the sensor augmented, they dropped to 7.5. So this is the most significant result of the CGM that has been reported so far. This was a 1-year trial. The same group, they looked at nocturnal hypoglycemia in the patients who participated in this study. So they analyzed their glucose from midnight to 6 a.m. in 176 patients, what they defined as hypoglycemic event was if the patient had at least 2 CGM glucose readings below 60 within a 20-minute period. So this is quite frightening that about a third of the patients, and a lot of these patients are very young, about a third of them spend at least 2